Vasculitis Syndromes. Polymyalgia rheumatica, giant cell arteritis, Wegener's granulomatosis, polyarteritis nodosa. What is vasculitis? Disease characterized by inflammation of blood vessel walls, leading to altered blood flow through obstructed walls. This causes ischemia and tissue damage. In addition, there is an intense inflammatory RXN causing further systemic signs and symptoms. Can be fatal. You should suspect vasculitis. Unexplained signs and SXS. Multi-system disease. Unexplained elevated DSR/SHE. Skin lesions, palpable purpura. Ischemic vascular changes, Raynaud's, gangrene, livedo, claudication. Glomerulonephritis. Mononeuritis multiplex. Intestinal angina. Inflammatory ocular disease. Arthalgia/arthritis, myalgias. Sudden visual loss/headache. Select vasculitis polymyalgia rheumatica. Giant cell or temporal arteritis. Wegener's granulomatosis. Polyarteritis nodosa. Polymyalgia rheumatica, PMR. Most benign of the group. Common, 50/100,000ths, age greater than 50, average age 75. Highest prevalence in Northern European ancestry, females males. Cause unknown. PMR clinical presentation. Usually abrupt onset. Intense morning stiffness and pain that can last all day involving the shoulders and hip girdle area. No small joint involvement. Muscle strength normal. Fatigue and anorexia common. Elevated SHE and DSR, anemia of chronic disease, elevated platelets. 15% get GCA, more later. PMR treatment low-dose steroids, 10 to 20 mg/day. The only drug that works. Look to normalize the SHE and DSR. If they continue to be elevated, rethink the DX, Beroneoplastic syndrome or GCA. Usually self-limited, 65% of patients able to taper off prednisone by 1 year, greater than 85% in 2 years. Disease flares not uncommon as prednisone is tapered and may require dose adjustments. Giant cell arteritis can occur exclusively but often seen with PMR. Rare, 15/100,000ths. Age greater than 50. Cause unknown. Involves the medium/large blood vessels of the head and neck, including the blood vessels that supply the optic nerve. GCA pathophysiology. Unknown trigger causes inflammatory response with the release of IL-1 and IL-6. This leads to systemic symptoms and the infiltration of inflammatory cells into the adventitia of the temporal and other involved arteries. Typical histologic pattern, giant cells. GCA clinical presentation. Variable. Scalp tenderness. Temporal headaches. Jaw claudication. Sudden loss of vision. +/PMR/SXS. Rare upper extremity claudication due to subclavian involvement. Constitutional SXS, FUO, weight loss, fatigue. Bounding or absent temporal artery pulses. Rarely subclavian bruits. GCA diagnostic studies. Temporal artery biopsy is the gold standard. Elevated DSR and SHE, usually levels higher than in PMR. Anemia. Elevated LFD not uncommon. Treatment of GCA. High-dose steroids, 60 mg/day, is the only drug that works. Slow taper over time, usually 1 to 2 years. Some patients require low dose, less than 10 mg/day, chronically. GCA complications: blindness, scalp necrosis, lingual infarction, aortic dissection/aneurysm, Complications from high-dose steroids, osteoporosis, cataracts, elevated blood sugars, weight gain etc. Wegener's granulomatosis, WG. Potentially fatal vasculitis involving small vessels. Rare, 3 to 14/million, more common in whites, any age but rare in children. Pathology shows necrotizing granulomas usually in upper airways, lungs and the kidneys. WG pathophysiology. Complex immunopathogenic events in which the production and activity of ANCAs, usually C-ANCA, play a central role. These autoantibodies interact with primed neutrophils to cause vascular injury and necrosis. Histologic lesions show granulomas. WG clinical presentation. Variable, multi-system involvement. Organs. Eyes, episcleritis/scleritis, proptosis due retroorbital mass. SNES, rare mass lesion. Upper airway, otitis media, nasal congitis, sinusitis with purulent drainage and epistaxis, ulcerations, subglottic stenosis. Kidney, nephrotic syndrome, proteinuria, renal failure. Skin, palpable purpura due to leukocytoclastic vasculitis, bioderma gangrenosum, panicolitis. Lung, cough, hemoptysis, hemorrhage, risp failure. Cardiac, pericarditis, conduction abnormalities. Systemic, fever, night sweats, weight loss, fatigue. Palpable purpura. Eye involvement. Face involvement. WG diagnostic studies. Presence of C-ANCA, cytoplasmic staining pattern anti-neutrophil cytoplasmic antibodies plus clinical picture is often enough to make the diagnosis. It is plus 80 to 90% of generalized WG. If the C-ANCA is, tissue biopsy of lung or kidney is recommended. Limited refers to disease limited to the airways. C-ANCA often is. Additional labs elevated SPI and DAS. Anemia, leukocytosis, and thrombocytosis. Elevated SPI. Active urine sediment with red cell casts, hematuria and proteinuria. WG clinical course/progression. Prior to immunosuppression therapies, WG was uniformly fatal. Now survival rates almost 90% with aggressive treatment. High-dose steroids and cyclophosphamide are cornerstone of therapy. Methotrexate or azathioprine sometimes uses steroid-sparing agents. Polyarteritis nodosa, PAN. Medium vessel vasculitis can be caused by Hep B. 5/million cases. Peak incidence 50s and 60s, slightly more common in males. Pathophysiology. In Hep B SOC cases immune complexes play significant role. In non-Hep B cases, the pathophysiology is less understood. Clinical presentation. Systemic, fever, fatigue, weight loss. Abdominal pain due to mesenteric angina/ischemia. Mononeuritis multiplex. Myalgia/arthalgia/mild arthritis. Hypertension. Skin, levadoreticularis, palpable purpura, fingertip ulceration, subcutaneous nodules. Testicular pain or tenderness. Levadoreticularis. Subcutaneous nodules. Complications of panchronic renal failure, bowel perforation. Stroke/cerebral hemorrhage due to HTN. Foot/wrist drop, wrist drop. Labs of pan elevation of acute phase reactants, ESR, SPI etc. Absence of ANCA. Elevated transaminases, decreased albumin. Plus/Hep B. Urine, proteinuria and hematuria without casts. Imaging studies of pan. Mesenteric and or renal angiography is the test of choice. Biopsies seldom done. Angiogram.